So welcome, I'm Philippa Jefferies from River Publishers, and today I'm talking to Pranela Rameshwar, Professor of Medicine, Hematology Oncology at Rutgers New Jersey Medical School and one of the editors for the River Publishers book series in Biotechnology and Medical Technology Forum. And today we're going to talk a bit about her experience and research interests as well as the book series. So welcome, Pranela. Thank you so much for joining me today.
Yeah, thank you. Thank you so much, Philippa.
Great. So just to start, you've had a strong research interest in the translation of stem cells, so how they can be used, particularly their relationship with aging. Could you start perhaps by talking a little bit about your research here?
Oh, sure. So I have a history of working with the hematopoietic stem cell, and that evolved into all kinds of stem cell. One of them was the earlier, or actually some of the earlier work publications in mesenchymal stem cells, or was a publication from our lab showing, validating actually other people's work, that mesenchymal stem cells have veto property, meaning that they could be used as to suppress inflammation and any kind of inflammatory disease. And that after that, it evolved in parallel. I started to work with breast cancer dormancy, because it was very clear at that time that when recurrent breast cancer, the source of those cells were coming from the bone marrow. So I had a simple question: why are these cells existing for decades in bone marrow, and what's causing it? And that became a 20-year study actually. And now that study has evolved in that it led to, well, are they coming into the bone marrow as dormant cells and just lying dormant, or are the bone marrow cells helping them to become dormant? And what I recently published was showing that microvesicles coming from those same mesenchymal stem cells that I was studying is entering these breast cancer cells and initiating dormancy. And when that dormant, that sleeping property starts, then those same mesenchymal stem cells accompany like a cellular chaperone towards close to the endosteum, where they just lie very dormant and making it easy to get into the bone actually in the endosteum. And what was interesting, it validates earlier studies that show those mesenchymal stem cells were protecting the cells that you want to get rid of by chemotherapy, which was the cancer stem cells. So in other words, the current treatment are not eliminating those cells.
Okay, so people are having breast cancer once, and then those cells are remaining dormant within the bone marrow and then coming back later. Okay.
Right, yes. And the aging study came about where actually I was approached and asked, can we mix young and old cells? And that came from the studies with the parabiosis models, where you sew two animals together. And what that led was taking young cells and restoring the aged hematopoietic system. And that's important, because if you, as we old, I mean, we don't want to use plastic surgery and make people 16, but if you're going to live longer, you should be healthy. So if you can restore the hematopoietic system, then you can have a competent, I shouldn't say young, a competent immune system. And that should be able to help with infection, even the vaccine. I mean, we see now older people are getting vaccines. For example, in the influenza vaccine, they're giving double the dose of people who are 65 and over. But if we can restore those hematopoietic system, then we can be able to have, and what we have found is that when you do that, you also affect the brain. So it seems like the immune system also affect the brain. But it's an expensive technology. So we have recently, for the past year or so, we have revised the system and make it cheaper. So
and how do you do that? You introduce kind of younger stem cells, and that kind of rejuvenates them?
Yes, it rejuvenates the aged hematopoietic system, and that you have a young system. And I could tell you, people in their 70s and 80s now have a hematopoietic system of someone of your age, for example. And it seems like it has been a stable rejuvenation. It's been stable. It's been 5 years now, and those same people, they still haven't maintained. young hematopoietic system.
Okay, and what kind of, I guess, diseases and stuff does that help against that you talked about the immune system?
So vaccine infection, like for example, right now, I'm convinced if that technology could go to patients right now, it can help the older people and the vulnerable population. I say people in nursing home, for example, and they now have a competent immune system to deal with this infection. What about immune therapy, for example? They're giving immune therapy for cancer when those patients have no immunity to begin with. So it never make any sense to me. So why not combine the two therapy together?
Okay, interesting. So our immune system is the quality of it is directly related to kind of the aging of these cells.
But you know the truth is everything has merged into one. You know, all my research, you learn from one area to extrapolate to the other. So it comes with experience. Like I'm in our medical school is in Newark. Newark is a good representative of all the metropolitan areas where you have disparity in healthcare.
Yeah.
And so most of those patients being diagnosed with cancer, for example, breast cancer for the first time, a late stage metastatic breast cancer. So I've just submitted a grant yesterday to MetaViber Foundation, where I'm going to use all my research now to see if we can develop a new treatment. Maybe repurposed drugs already exist. And so rather than giving them the same toxic treatment over and over, you get a treatment, then the metastatic cancer comes back, and you continue the treatment, and you just do that until the patient die. I just felt it, and I think it's unacceptable. And I mean, we can't. I don't know if we should wait. Scientists should not wait until the social problems are solved. But what we could do is to have some kind of treatment. Because you know with health disparity, you're going to have late stage. So while the social issue is being dealt with, why don't we have a new treatment? And that lead into, I know you didn't ask me this question as yet, but that is what lead me why I'm working with River Publisher so much into this new series, translational series, because I want to highlight this. This translational series will highlight, okay, you're doing basic science, there's societal problems. How can we merge the basic science with societal problem and eliminate things like disparity, improve healthcare, improve drug, and maybe for the younger people, teach them that science, you can't have effective healthcare unless you do the basic science.
Actually, now you're talking about the book series itself. Like you said, you're one of the editors for that, and it encompasses a variety of topics in basic and translational medicine. And biomaterials and things like this. I was just wondering, just to finish, kind of what are some of the key technologies of research you're particularly excited about that's coming out in this area at the moment? Perhaps some of the more multidisciplinary research.
Well, you know, I know people may be wondering, and we have to make that quite clear. Why do we have biomaterials? Why do we have engineer? Why do in that series? Well, it goes back to what I just said, that to improve healthcare, you have to improve the translational part. And to improve the translational part, you have to involve all the disciplines. For example, an engineer is making a device, a medical device. Can that engineer alone do it? You need maybe the clinical expertise. And when you have the engineer and that clinical expertise, how do you test a device for biosafety? You need the biologist. And that's the whole purpose of the series. And I think we have to make this quite clear of the strength of the series.
Okay. And would you say your research is a particular example of that, of taking, looking at things from a slightly different angle to produce something that's very practical for healthcare?
Well, there's another issue too. I was trained, I did my PhD together. It was two different departments. One was basic science, one was in medicine, actually.
Okay.
And so I was trained to think like a translational scientist.
Okay,
and
from the beginning.
Yes, and the students who, like I would go, normally you go to graduate students go to a basic science seminar. I went to a basic science seminar, but I also went to grand rounds, clinical grand rounds. And so as a student, I started thinking, they have these black boxes. I'm learning the science. How can I fill the black box? And so the students, the PhD students in my lab, I encourage them also to go to grand rounds and and because they see in my lab, we interact with the clinical faculty, surgeons, medicine, all subspecialty. So my students are also learning that interaction. And I think that we will do good with graduate students in medical schools. We have an opportunity here to train a set of scientists to think translational, but it has to be done in a more appropriate way.
Okay, fantastic. I'm afraid we're kind of running out of time, but thank you so much for joining me. It's been really interesting, and I look forward to seeing where the series goes.
Yes, thank you so much, Philippa.